Bismillahir Rahmanir Rahim. Our lecture today is about the acute tonsillitis, which is a very important and common problem in the population. And as I said previously, it is important for any physician. To see the importance of this problem, we go to the differential diagnosis of acute tonsillitis. The first is infectious mononucleosis, tonsillar concretions or tonsilloliths, diphtheria, pemphigus, acute necrotizing ulcerative gingivitis, or we call it Vincent angina or trench mouth. We spoke about it in the last lecture. Tumors, different tumors, whether benign or malignant, where there is swelling. Some they think that this is acute tonsillitis. Aphthous ulcer, especially if it is on the tonsils and there is a big ulcer with membrane. Agranulocytosis and scarlet fever. Now we go to the complications of tonsillitis. The complications of tonsillitis can be broken down into non-suppurative complications. First is scarlet fever. It is secondary to acute streptococcal tonsillitis or pharyngitis with production of toxins by the bacteria. Manifestations include an erythematous rash, severe lymphadenopathy with sore throat, vomiting, headache, fever, erythematous tonsils, and a yellow exudates over the tonsils, pharynx, and nasopharynx. A strawberry tongue with a rash and large glossal papillae is a good diagnostic sign. Diagnosis is made by culture and positive dictase, which is an intradermal injection of dilute streptococcal toxin. Treatment involves IV administration of penicillin G. The second non-suppurative complication is acute rheumatic fever. A patient with acute rheumatic fever who does not comply with penicillin prophylaxis should have a tonsillectomy and adenoidectomy, because patients who have undergone surgery have a lower infection rate with beta hemolytic streptococcus. The third one is post-streptococcal glomerulonephritis. May be seen after both pharyngeal and skin infections. Typically, an acute nephritic syndrome develops 1 to 2 weeks after streptococcal infection. The infection is secondary to the presence of a common antigen of the glomerulus with streptococcus. Penicillin management may not decrease the attack rate, and there is no evidence that antibiotic therapy affects the natural history of glomerulonephritis. That's why a tonsillectomy may be necessary to eliminate the source of the infection. Now we go to the suppurative complications of acute tonsillitis. First is the peritonsillar abscess, or we call it quinsy. Most commonly occurs in patients with recurrent tonsillitis or in those with chronic tonsillitis that has been inadequately treated. The spread of infection is from the superior pole of the tonsil with pus formation between the tonsil bed and the tonsillar capsule. This infection usually occurs unilaterally and the pain is quite severe, with referred otalgia to the ipsilateral ear a few days after the onset of tonsillitis. Drooling is caused by odynophagia and dysphagia. Trismus is frequently present as a result of irritation of pterygoid musculature by the pus and inflammation. There is gross unilateral swelling of the palate and anterior pillar with displacement of the tonsil downward and medially with reflection of the uvula toward the opposite side. Regarding the treatment, the choice between needle aspiration and incision and drainage in the management of peritonsillar abscesses is controversial. Traditional management has consisted of incision and drainage with tonsillectomy 4 to 12 weeks later. Some surgeons advocate immediate tonsillectomy or quincy tonsillectomy as definitive management to ensure complete drainage of the abscess and to alleviate the need for a second hospitalization for an interval tonsillectomy. If incision and drainage or needle aspiration fails to drain an abscess adequately, a quincy tonsillectomy is indicated. Quincy tonsillectomy is particularly favored in children because they are likely to experience further episodes of tonsillitis, and needle aspiration or incision and drainage with a child under local anesthesia is often difficult or impossible. The second one, parapharyngeal abscess. An abscess can develop in the parapharyngeal space if infection or pus drains from either the tonsils or from a peritonsillar abscess through the superior constrictor muscles. The abscess is located between the superior constrictor muscle and the deep cervical fascia and causes displacement of the tonsil on the lateral pharyngeal wall toward the midline. Involvement of the adjacent pterygoid and paraspinal muscle with the inflammatory process results in trismus and a stiff neck. Patients with parapharyngeal space infection characteristically exhibit fever, leukocytosis, and pain. Initially, lateral pharyngeal space infection should be managed with aggressive antibiotic therapy, fluid replacement, and close observation. Surgical drainage is required to bring about resolution of these infections. Now we go to the retropharyngeal space infection. The superior limit of the retropharyngeal space is the cranial base. Inferiorly, the retrovisceral space extends into the mediastinum to approximately the level of the tracheal bifurcation. The buccal pharyngeal fascia is adherent to the prevertebral fascia in the midline, so that infection in the retropharyngeal space is unilateral. In general, the most common affected age group by retrovisceral space infections are children under the age of 4, as the greatest number of retropharyngeal lymph nodes are found in this age group, and usually as a complication of upper respiratory tract infection, tonsils, nose, sinuses, adenoids, nasopharynx, or others. And retropharyngeal space infection manifested as high fever, odynophagia, and dysphagia, drooling, cervical rigidity, hot potato, voice, airway obstruction, and unilateral bulging of posterior pharyngeal wall. The diagnosis is by lateral neck radiography, CT, or ultrasonography may help ascertain whether there is cellulitis or true abscess. Treatment is fasting, IV antibiotics, and emergent surgical drainage. Really, we have many details regarding these problems, but in summary, we are giving these lectures. Now we go to indications for tonsillectomy. Really, this is a very common operation, and the indications must be evaluated well before taking a decision for tonsillectomy or adenotonsillectomy. We have absolute and relative indications. The absolute indications for tonsillectomy: first, obstructive sleep apnea or cor pulmonale; 2, tonsillitis resulting in febrile convulsions; 3, malignancy or suspected malignancy; 4, persistent or recurrent tonsillar hemorrhage. Some relative indications for tonsillectomy: first, 7 infections or more in 1 year; 5 infections per year for 2 successive years, consecutive years; 3 infections year for 3 consecutive years; more than 2 weeks missed from school or work in any 1 year; 2, peritonsillar abscess, tonsillolithiasis; 4th, halitosis after exclusion of other causes like bronchiectasis, lung abscess, oral infections, or smoking or other problems causing halitosis; 5th, hypertrophy causing eating or swallowing problems; 6, diphtheria carriers; 7, orofacial and dental abnormalities. What are the contraindications for adenotonsillectomy? These are blood discrepancies like leukemias, purpura, hemophilia, etc. And if there is an absolute indication for tonsillectomy, correction of the underlying cause must be done if possible, and the opinion of the hematologist must be undertaken. 2, cleft palate, otherwise will cause scarring and adversely will increase speech cleft, causing hypernasal speech and more difficult to be corrected. 3, acute infections. Recent upper respiratory tract infections are absolute contraindications and should be postponed for 3 weeks unless there are urgent obstructive symptoms. Otherwise, there are more complications, especially bleeding and the complications of general anesthesia like pulmonary complication and others. 4th, uncontrolled systemic disease like diabetes mellitus, heart disease, or others. HB is less than 10 gram for DL. 6, allergic rhinitis and asthma unless there is convincing evidence of true tonsillar infections. Now we go to the post-operative complications of adenotonsillectomy. Here we speak generally about the adenoid and tonsillectomy surgery. Really, most surgeries we do adenoid and adenoidectomy and tonsillectomy in the same operation because the pathology always affecting together. Serious post-operative complications secondary to surgery of the tonsils and adenoids are primarily related to pain, hemorrhage, airway obstruction, post-operative pulmonary edema, velopharyngeal insufficiency (VPI), or hypernasality, which is primarily related to adenoidectomy and nasopharyngeal stenosis. Other complications like tooth injury or aspiration, pain referred to the ipsilateral ear, and chronic post-operative pain related to fibrosis and calcification of the stylohyoid ligament, Eagle's syndrome, may be encountered. Post-operative hemorrhage. Post-operative hemorrhage after adenotonsillectomy. Post-operative hemorrhage is the most common serious complication of adenotonsillectomy. Reported post-operative hemorrhage rates range from 0.5% to 10%, although variable rates have been reported with different surgical techniques. Bleeding can be divided into intraoperative hemorrhage, may be related to an underlying coagulopathy or possibly to a major arterial damage in severe cases, may be due to aberrant internal carotid artery. Steps to control major intraoperative hemorrhage include use of suction cautery, ligation, but the suture ligation may damage the underlying arterial vessels, thereby worsening the bleeding or possibly leading to delayed post-operative hemorrhage. C. Placement of a pack in the tonsillar fossa and over-suturing of the tonsillar pillars to provide constant compression of the fossa. Now we go to the immediately post-operative or called primary hemorrhage, which is within the first 24 hours. In most cases, within the first 8 hours, and this is dangerous, especially in the early hours or in the early time. Why? Because the blood in the airway at this time may cause laryngeal spasm and asphyxia, as cough reflex is not fully established during recovery from general anesthesia, and also may cause dehydration. It should be controlled with cautery and or suture ligation in the operative theater under GA. 3. Delayed hemorrhage or called secondary hemorrhage after 24 hours. Delayed post-operative bleeding, although typically not as dangerous as intraoperative or immediately post-operative bleeding, may be fatal if not managed appropriately. The most common time for delayed post-operative bleeding is between the 5th and 7th post-operative days, and usually due to infections. To summarize this regarding the bleeding and other important complications, Below are the most common complications of adenotonsillectomy and summary of presentations with management options. Really the most important complications. This hemorrhage post-tonsillectomy presentation, and you can see here in this table the complications post T&A adenotonsillectomy. معناها ممكن يكون عندنا airway obstruction occurs in the first 4 to 24 hours, palatal swelling, hypopharyngeal secretions, and here the management. Dehydration, especially in children at the summertime, because there is pain, so the child cannot take fluids. Here you can pour oral intake, dry mucous membranes, lethargy control emesis if present, IV hydration, parental education and pain control. Persistent VPI, velopharyngeal insufficiency after adenoidectomy, hypernasal speech, lasting, if it is lasting beyond 2 months, post-surgery, we need speech therapy and palatal surgery. Now we go to a problem. Many times we are facing a mass in the oropharynx, especially at the tonsillar area, and we must know the differential diagnosis of this mass. Sometimes a mass may be missed as acute tonsillitis. Other differential diagnosis of tonsillar mass, in addition to acute tonsillitis, is tonsillar concretions or tonsilloliths, peritonsillar abscess, infectious mononucleosis, parapharyngeal space mass, and tumors. All tumors, benign or malignant, like lymphoma, squamous cell carcinoma, pleomorphic adenoma, adenoma, or another tumors. Now we finished the lecture, and if you have any questions, comments, you can send to me any message to the Google Classroom, or as I said, you can contact with me by any way. Thank you too much.